very good morning, good afternoon, and good evening to all the doctors and students pursuing hematology who have logged in not only from India but various parts of the world. Welcome to the live webinar on Fanconi's constitutional aplastic anemia, brought to you by Mumbai Hematology Group and ably supported by Intas Oncology. I am Ashish Shah, heading marketing of Intas Pharmaceuticals Oncology Division, and we welcome you all to this academic feast, which is going to be really interesting. This series, which started during the COVID time, is the longest lasting educational series, okay, uh, which has just not stopped and it's going, and it's because of the efforts uh, and the vision of Professor Dr. M.B. Agarwal sir, and we all the doctors and the students in the field of hematology owe a lot to Professor Dr. M.B. Agarwal sir. Thank you, sir. Now, Dr. Amit Khurana needs actually no introduction because Dr. Amit Khurana has taken ahead the legacy of Mumbai Hematology Group, conducting the weekly webinars. And Sir is a very known face in the field of hematology, not only in India but the nearby countries. And Sir, Dr. Amit Khurana is ensuring that the weekly webinars, okay, are ongoing, absolutely spotless and flawless. Thank you for taking things forward. And Dr. Amit Khurana sir, now would request you to take the proceedings forward.
Thank you. Thank you, Mr. Ashish. Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is no other than Dr. Regis Pifol from Paris, France, and he's going to lecture us on Fanconi's constitutional aplastic anemia. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Intas, and very well managed by Perfect Square. I thank Mr. Arun Hegde, Dr. Manoj Kumar, and the team from Intas, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Sashi Bansal from Jaipur, our guest speaker for the day, Dr. Regis Pifol from Paris, France, all our discussants who are themselves very eminent hematologists as well as pediatric hematologists, and you participants for sparing a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. We do not have webinars during the next weekend, and this is in the view of the midterm conference of MHG, which is going to be held the next week. Just to note that. And now it's time to introduce our discussants for the day, and they are displayed here in alphabetical order. I will just name them. You have Dr. Akanksha Garg from Ahmedabad, Dr. Deepa Rani from Varanasi, Dr. Durga Devi from Chandigarh, Dr. Gopinathan from Chennai, Dr. Gurpreet Kaur from Kolkata, Dr. Jaswantini from Chennai, Dr. Nilesh Vasekar from Nashik, Dr. Rajan Yadav from Ahmedabad, Dr. Ramesh B from Madurai, and Dr. Shruti Toshniwal Mantri from Aurangabad. And now it's time to introduce our guest speaker for the day. We have with us Dr. Regis Pifol from Paris, France. Let me introduce Dr. Regis to all of you. He is the head of the Hematology and Bone Marrow Transplant Department at Hospital Saint Louis, Paris, France. He received his MD degree from the University Paris, Lariboisière in 2003, and his PhD degree in immunology from the Pasteur Institute in 2006, where he worked on regulated T cells in graft versus host disease after hematopoietic stem cell transplantation. He was also trained in hematology at Paris hospitals and did his postdoctoral fellowship at the Hematology Branch, National Institutes of Health, USA, from the year 2008 to 2010 on aplastic anemia and paroxysmal nocturnal hemoglobinuria. He obtained his tenure professorship position in 2014. He is responsible of the French Reference Center on Aplastic Anemia and PNH, as well as of the French Organization for Rare Hematological and Immunological Disorders since 2016. He is currently the head of the Hematology and Bone Marrow Transplant Department at Hospital Saint Louis, Paris, France since the year 2022. His research interest focuses on bone marrow transplantation, bone marrow failure, and paroxysmal nocturnal hemoglobinuria. He is the principal investigator of many research studies on bone marrow failure at the national as well as international level. He is the author as well as co-author of more than 350 papers quoted in PubMed and is a regular reviewer for the journals like New England Journal of Medicine, Blood Hematologica, British Journal of Hematology, Biology of Blood and Marrow Transplantation, as well as bone marrow transplantation. And today he's again with us and is going to lecture us on Fanconi's constitutional aplastic anemia. But before he does that, we have our special guest and chief guest for the day. We have with us no other than Dr. Shashi Bansal from Jaipur. Let me introduce Dr. Shashi Bansal to all of you. Dr. Shashi Bansal is Senior Consultant and Head, Department of Pathology at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. She did her MBBS from Maulana Azad Medical College, New Delhi from the year 1997 to 2002. This was then followed by MD from Lady Hardinge Medical College, New Delhi from the year 2003 to 2006. Subsequently, she did her DNB, National Board of Examination, in 2007. She has vast experience in hematopathology, including flow cytometry, bone marrow aspiration, trephine biopsy, and lymph node histopathology, especially for hematolymphoid malignancy, including immunohistochemistries. Her main area of interest are flow cytometry and IHC on hematolymphoid malignancy. She is associated with teaching under NBE for the past 11 years. She is the guide as well as co-guide for DNB and PDCC students. She has been the examiner at various occasions, and she has presented many presentations in national and international conferences as well as publications in various peer-reviewed journals. She has organized various hematology CMEs, update, workshop, and quiz competition. She received the Best Oral Paper Presentation awarded by Delhi Society of Hematology in the year 2008. She is also presently the Joint Secretary of Rajasthan Chapter of IAPM. She is a life member of IAPM, ISHBT, TCS, PPS Raj, and an active participant as well as faculty member of various CMEs, workshops, and hematology conferences. It's my privilege to welcome Dr. Shashi Bansal to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, ma'am.
Ma'am, you are on mute mode.
Muted, ma'am.
Very good morning to everyone. It's a truly privilege to be here with you for this distinguished academic gathering. I would like to begin by expressing my heartfelt appreciation to the Mumbai Group of Hematology and Dr. Ambi Agrawal sir for giving me this opportunity and their unwavering dedication and leadership in the organizing this event. Their consistent effort to spreading the medical knowledge and raising awareness and building a strong community in the field of hematology is truly inspiring for all of us. In the today's digital era, the online platform has become a powerful tool to break down the geographical barrier. They allow us to bring together expert, young doctors, students, and healthcare workers from all over the part of the globe. This digitalization of the knowledge ensures that the most current medical advances reach every corner of the needed the most, whether it's an urban center to the most remote rural region where the healthcare facilities are scaled. This is an exciting time in the medicine. The pace of the medical discovery is faster than ever. Early detection of the blood disorder, highly effective targeted treatment, and the personalized care are no longer are just a dream. They are the realities now. And what we are witnessing today is not just a scientific advancement. It is a profound transformation in the field of medicine. And you, the young learner, are the future contribution of this journey. The journey of becoming a medical profession is not easy. The medicine never stands still, neither should we. It is always evolving. So the lifelong learning is the backbone of the clinical excellence. Yes, keep learning, keep striving, but do while maintaining a balanced life. That is my motto in my life. In the demanding profession, the balance is not a luxury. it is a necessary. So we have to take care of that part also for the holistic growth and development and continuous learning and development. So I hope today's session offer you the new perspective, spark you the curiosity, and inspire you to combine the pushing the boundary of what is possible in hematology and medicine. I have learned the medicine hematology in a mathematic way, starting from the peripheral blood to bone marrow to the flow cytometry to the molecular diagnosis. So as I start my diagnosing the thing from the peripheral blood till the molecular level. So we are the, and I've learned so many things from the online platforms because in the Jaipur, every time it's not possible to go to the higher centers. So we are the fortunate to be the part of the seminar like this, where we can hear from the leading expert, ask a difficult question, and challenge and the boundaries of current knowledge. Everything is not written in the book, but they are something which is come from the experience. So let's begin with this academic feast, an opportunity to share the knowledge and learn from each other and grow together as a medical community. And once again, and thank you again, my best wishes for the truly productive, inspiring, and exciting and enriching session ahead. So thank you very much. And my webinar is open. Thank you very much.
Thank you, ma'am, for this inspiring words and wonderful words of wisdom. And thank you for accepting our invitation as our chief guest for the day. Thank you so
Thank you.
much, ma'am. And now, Dr. Lator, the screen is yours. Please go ahead.
Thank you very much for this very kind introduction, and thank you for hosting me. I'm always impressed by the numbers of meetings you're organizing and the way you're doing it. So really congratulations, and it's really a way to have a kind of common education topics and spots, and as you are saying, discussion is an exchange is really the soul of our community, of hematology. So I'm just gonna cut the picture. No worries, it's just to be sure that the Wi-Fi is working well. Now sharing my slides, so no worries because you won't see it immediately, but that now you should be able to see it. So again, thank you. Thank you for hosting me. I'm going to speak about a very complex disease, a disease that is also very rare. And that's one of the reasons that sometimes we're a bit, surprised, or we don't know how to do and the ways to share our experience. In St. Louis Hospital, we had the chance to be all trained by Elian Gluckman. So I'm sure the name is saying something to almost all of you. And one of her favorite topics, was Fanconi disease. So first of all, of course, the disclosure related to bone marrow failure, especially. And so just to introduce my talk, basically, Fanconi disease is of course a bone marrow failure, and you remember that we were discussing a lot. I mean, we're going to speak already about the aplastic anemia, about PNIH, about all those acquired disorders, and then there are the other ones. I mean, we have when we are the diagnosis with bone marrow failure, there is 80% of acquired disorder, but we have also 20% of inherited disorder, and Fanconi is belonging to this, as you can see here. We have Schwarzman diamond syndromes, we have dyskeratosis congenita, and the most frequent inherited disorders is Fanconi anemia. So this is what we're going to speak about. The marrow is empty. We already spoke almost 6 months ago about the screening, the genetic screening of patients with bone marrow failure, and how we can discriminate between acquired and inherited disorders. So I'm not going to do it again, obviously. We are considering now that we had a patient that has a biopsies, the diagnosis of aplastic anemia has been confirmed. It's not an AML, it's not MDS, and it's not a myelofibrosis. And then we go through the genetic screening, and most of the time we'll see what make us think about Fanconi anemia. And now we're going to speak about this disease itself. So the disease has been described a long time ago. As you can see, it was Guido Fanconi. He was an hematologist, and he was surprised by the association in some kids of the growth retardation, but there's also some skin involvement, and that kept the name in French, what we call tache café au lait. That's a specific name. And the patients were presenting some bone marrow failure associated with a polymalformative genetic syndrome, and especially, as you can see in the picture, with facial dysmorphia. Those patients were also presented possibly other malformations, especially they can have only one kidney, they can have an absence of the TUMPs, they can have cardiac malformation. So this is really a syndromic disease that is involved in, of course, bone marrow, and that's the reason why the entry is most of the time done by the hematologist, but is also involving many other organs. So Fanconi is a very I would say evolutive disease. It's a rare disease. We have in France about 400 patients, so that's really rare. We have 66 millions. And it's a rare disease. And what is even more difficult is that it's even rare, it's heterogeneous and clinically and genetically speaking. And this disease is a prototype of the DNA repair disease. And so with time, we see many symptoms coming in, many symptoms related to this DNA repair involvement. As you can see, when the patients are kids, you can do the diagnosis and specific congenital signs. These patients, as I was telling to you, are presenting growth retardations. They are short size. There is a specific face presentation, as you can see on the left down side, this very nice little boy who authorized to diffuse this picture. This is a typical Fanconi anemia face. And as I was saying, those spots you can find on the skin with our calling cafe au lait. You see here the many spots that you can see in those patients. And then, I mean, at the very beginning, the cytopenias are mostly mild, and the diagnosis is done because of those malformations. And as you can see, you have very specific presentation. Here you have the TUMPs that is totally absent. But then with time, I mean, of course, the other signs are coming in. And one of the specific signs is the hematological bone marrow failure that is present in almost all patients before the age of 20. So we say that 90% of Fanconi patients will present cytopenias and will probably need transfusions before the age of 20. And then, since the disease is still going on, it's a genetic disease, there is no, and we'll see, there is a little bit of natural genetic controller, let's say, rescue. But usually the disease is evolving, and then of course, if you have a DNA repair problems with time, you have cancer. And the most frequent ones is about secondary myelodysplastic syndrome and AML, but also solid cancer. And you can see here a very specific head and neck squamous cell carcinoma. That was one of our patients. And this is very difficult because the main features in those patients is that they are highly sensible to chemotherapy and radiotherapy. So we are very limited in terms of treatment because they are not supporting, because of the DNA repair problems, the approach by chemo and radio. And so this is quite difficult to treat patients, especially head and neck squamous cell carcinoma, when you cannot have those two very important treatments in the field of the patient. So that's the reason why we are always pushing forward to do very, very specific and regular screening in those patients, especially in the males and in the gynecology in women, because we want to treat the cancer as quick as possible. And most of the time, if you want to be curative, the only way is clearly to go for surgery, because you cannot afterwards do chemo or radio. So when the patient is presenting metastasis, or if the disease is not local anymore, then it might be a problem because you could not be curated. So as you can see here, there is a kind of continuum in this disease between BMF syndrome, MDS, and AML. As you can see, the pool of stem cells is really reduced from the birth, and this is genetically driven. And then with time, you will observe pancytopenia in those patients and aplasia. And as I was telling to you, since there is a kind of genetic instability because those few cells are trying to make the job, then you will have with time some clonal evolution with a very specific and regular and hierarchical mutations that will go through secondary myelodysplastic syndrome in AML. And that's a work that did Jean Soulier in his lab in Paris for the last 25 years. He described this oncogeny in those patients. It's really a model for us of ontogeny. It's I would say a natural model, a human natural model of ontogeny coming from, let's say, few stem cells at the beginning, at the birth, to pancytopenias and going through then MDS and AML. And as Professor Soulier was showing, we are finding some germline mutations from the very beginning. So it's really a disease from birth to death that is evolving, and where the clones and the clones dynamics are outstandingly important. So I was telling to you, this is a DNA repair problem, and that's how we understood what proteins were involved in Fanconi anemia. Basically, as you can see, this is something we know very well at the moment, is that we are facing a problem in the clearance of the DNA interstrand cross links, and I will call this ICL for a matter of clarity and simplicity. So you know that usually the FA core complex, that is again an aggregated a number of proteins, is signaling when we have those ICL, is signaling it to repair it. And of course, if there are mutations or if you have anything going on in this FA core, then you won't be able anymore to silence the damage. And if you're not able anymore, you will block the replication forks and the cells will die. On the other hand, if of course this FA core is normal, then you have the ICL detection, and then you have a process with nucleus cut and unhook the ICL DNA synthesis, homologous recombination, and at the end, you're able to have a division that is still going on, presenting and preserving the cells. And as you can see downstream, you have the implications of the BRCA2, BRCA1 genes, and that's also something that is related to Fanconi, that's, you know, is involving all those pathways, and you can find mutations or alterations in all these pathways and creating a Fanconi disease. We did, and that's Professor Soulier, we did the description of the genotype core of patients in France, and as you can see here, in 302 number of patients, you have mainly FANC-A mutations, and you see this is this protein that is in the FA core complex that is mainly responsible for most of our patients' disease, but you have also FANC-G, FANC-C, BRCA2, that is a very severe disease, this is the most severe disease, and FANC-D2 is also involved. So, as I was telling to you, this is a continuum. This is a continuum, and for clinicians, it's also difficult to take care about those patients because you do know that they are going to present troubles, especially cytopenias going through MDS, AML, and then squamous cell carcinoma. So you have to be really, really alert and very vigilant on those patients, following them carefully to be really, really tackling the disease that the patients was going to present and to be able to give the best treatment. In terms of diagnosis, this is a disease that is quite easy to diagnose most of the time. It's easy to diagnose because we are showing in the lab this hypersensitivity to interstrand cross-linkers. This is quite easy to see, and you see the very typical pictures here, and you see that you have those ICL hypersensitivity, and that makes the diagnosis easier. Sometimes no, we are then, of course, looking for the genes and looking to what kind of proteins is involved and mutated. So we are gonna do a genetic screening. And the other thing that is very important Of course, it's an autosomal disease, so you need a B allelic mutations. But the other thing that you need to know is very important, and we'll see in a minute that it can have some natural genetic rescue in that disease, and that's the reason why sometimes the cross-linking, the breakage tests might be negative, and that's the reason why we are also testing some germinal material, doing some skin fibroblast biopsies that we are, of course, touching in cultures and looking on because those germline material is never presenting some natural genetic rescue. So if we go ahead and come back to clinic, this is the picture that is telling to you what our patients are presenting. So this is again Professor Soulier who put this in perspective. There was about 355 patients. As you can see, you have the cumulative incidence of bone marrow failure, and you see basically that I was telling to you at 20 years of age, 90% of our patients are presenting bone marrow failure. You have a mimicking of the cumulative incidence of stem cell transplant because this is the only curative treatment that we have to treat this bone marrow failure. I told you it's an inherited disorder, so there is no, for the moment, other treatment that might help those kids. So that's the reason why they go through a bone marrow transplant. There is also clonal evolution, and you see that in the patients that were not transplanted, you have a higher rates with age, and at 40 years of age, at least almost 50% of the patients will present a clonal evolution that might be MDS or AML, or as you can see in red, MDS and AML, or all clonal evolution, because all is not MDS and AML. And finally, you see in red, in green, sorry, the cumulative incidence of solid cancer in those patients. So you see how complex and severe is that disease. This is a non-malignant disease at the beginning, but then because of the DNA repair problems, the patients are in a way not able, of facing many cancers with age. So just to come back with the physiopathology of our patients and how it works. So you see you have mutations from the beginning in the fetal liver, and then you're, of course, presenting a bone marrow failure. So usually the patients are transplanted at that time, and that's also the stage where basically you want to do genetic therapy, gene therapy, sorry, and that was developed by our friend Juan Buren from Spain, who did a lot of work and presenting some very nice paper trying to treat patients at that stage. But the fact is that there is not a lot of stem cells, so it's very difficult to go through to harvest enough stem cells and then do the gene therapy and contribute to a restoration of the hematopoiesis. And the other thing that you have to think about in the gene therapy approach in Fanconi patients is, as I was telling to you, this is a disease not only on the bone marrow. This is a disease that is impacting all cells in those patients. So you're going to do gene therapy, of course, for hematopoiesis, but you're not going to do gene therapy of skin cancer or liver cancer or digestive cancer or so on. So that's very frustrating because it's difficult to cure the patients by itself. So what I was speaking with you and telling to you before is that we have some patients who have some natural genetic rescue, somatic genetic rescue. We have 15% of the patients who are going to rearrange with genetic reversion, as you can see on that draw, and then they will make the disappearance of these B allelic mutations, and then the patients will come back to an heterozygosity status, at least in the blood, make the patients able to have a normal count. So this is something that is really very important to know, because you can have some patients with a very typical presentation. They have a dysmorphism of face. They have, for example, some tache café au lait, and very early on, an squamous cell carcinoma and you're thinking, well, it's a bit strange, but anyway, the counts are normal. Then you go for chemotherapy, and the patient is presenting a higher rates of toxicity. It's just because it was a reversion. So when you look for his blood, he has a natural somatic genetic rescue that might his blood normal. So we have to be careful because you may mislead the diagnosis, and then first of all mislead the disease itself, but second, treating patients with chemo and radio and then killing him from these complications associated with treatment. So that's what I was telling to you, and then encourage yourself to read this very nice paper. I was showing how gene therapy is possible in Fanconi anemia, and you see that I was quite successful in the patients that were treated. However, again, we are treating only the hematopoiesis. That takes times, and you're not avoiding the cancer complications. So there is then the other clonal hematopoiesis complication. I'm sorry because it should be a little bit complicated, but that's very important because we know, when I told you, we know the natural history and the natural clonal hematopoiesis history in those patients. And we will see with time, because of genetic instability, some clones going on, some clones appearing, and then moving to transformation to MDS and AML. So you see these overall pictures, and I will tell you just afterwards and at time of treatment what should make us think about a possible MDS and AML transformation, and then what should make us act as transplanters to offer to those patients an early transplant and to avoid complications and to avoid them to go through transformation. But we also have, and the most typical clonal evolution is the acquisition of the 1q chromosome, the so-called plus 1q, that is helping the patients to go through some pancytopenias, improving the counts. And this is typically a clonal evolution that we are not going to take into considerations for treatment. And that's something that you should know, because then if there is this kind of clonal evolution, you're not going to proceed to transplant. And during all this process that is only hematopoiesis targeted, you see that the patients might present a solid cancer on the head and neck, squamous cell carcinoma. So now let's move to treatment of this very complicated disease. And as I was telling to you, the only curative treatment is bone marrow transplantation. This is, of course, possibly associated with toxicity. That's the reason why, as you may see, there is some specific approach and dosage and way of doing it in this population. And we'll see how to do it. And you'll see that the story will never be finished with transplantation, because of course you're going to rescue the hematopoiesis defect, the pancytopenia, the bone marrow failure, but you're not going to change. You're not going to change at all the rest of the body and the risk for cancer. So first of all, when we should give transplantation to the patients, it's not very different from the other aplastic anemia disease. We are indicating transplantation when the patient is presenting a severe, very severe bone marrow failure. We are using the so-called Kamita criteria, and when the patient is transfused, even if he's not reaching severity, it means that it should be transplanted, especially in inherited disorders like Fanconi anemia, because we do know that those patients are not going to be rescued naturally. And those 15% of patients with the genetic somatic rescue is very rare, and most of the time the patients are progressing to high rates of transfusions and need for transplantation. So usually we are advising to give transplantation before androgen therapy and before clonal evolution, but it's not always easy because you might have not a good donor, so you have to do something when you have only alternative donors, and sometimes it's better to go through androgens first. We'll see later on the results that we're expecting with androgens. And clonal evolution, as I was telling to you and I was trying to insist on, is very difficult because clonal evolution per se is not the same in Fanconi patients. I mean, usually we are speaking about clonal evolution, thinking about AML or MDS, but you will see that there is some specific sorry, complications that are clonal evolution but are not indicating transplant. And the other thing that you have to think about when speaking about Fanconi is definitely the donors. Because the donors, it's a family disease, so it might be impacts it and also sick when you're thinking about a transplant. And I remember perfectly, it was 20 years ago when I was assistant professor in the unit. I was doing a consultation with Professor Gluckman, and there was this patients coming in with his donor. His donor were both matched, they were matched sibling, and basically the donor was smaller than the recipient. And Mrs. Gluckman turned to me and told me, well, it's gonna probably be not the donor because I'm sure it's also suffering from Fanconi anemia disease. So this is also that you have to think is that yes, it's always good to have a donor in the family, but please be sure that is not also presenting the disease. So I'm always using this paper. It's an old one. It's a 12 years old paper that we did on behalf of the Severe Plastic Anemia Working Party of EBMT, but at least it was gathering a lot of patients, and it was in this matter helping to have some clear ideas of what we should do with Fanconi patients. As you can see, it was about 800 patients on a long time. It was about 40 years of transplant. The median age was 10 years. I told you, since the disease is presenting during the childhood, the patients are transplanting during that stage. The bone marrow was the main source of stem cells, which is normal because this is a disease where you don't want to have graft-versus-host disease, so you want bone marrow to avoid it. The conditioning regimen was fludarabine based, very few radiation, only for unrelated donors, because again, you don't want to irradiate those patients since you know that they are possibly presenting complications from radiation, and there was some T-cell depletion that were used. So first of all, as you can see, we did a lot of progress, and per se, transplantation improved a lot in those patients. That was especially in the unrelated setting. As you can see here, for geno-identical sibling transplantation, the progress are very few. But for the unrelated donors, there was a tremendous impact of the fludarabine approach and the match, the allelic HLA match donors that make us making so much progress. So this is basically the comparison of the approach of drugs in that disease. And as you can see, it's always better on the right side to give marrows and peripheral blood because this is the best way to avoid graft-versus-host disease. And there is nothing better than to go to the surgery room to proceed to a bone marrow harvest for those patients to avoid GVHD. Regarding fludarabine, I mean, really good improvement in both settings. For ATG, it's more discussable. As you can see, it's something that is really helpful in the unrelated setting. We were more hesitating in the sibling setting, but since you will see in a minute that chronic graft-versus-host disease is really increasing the risk for cancer, we decided also to add some ATG in the sibling setting too. So this is a conditioning regimen that we are using at the moment, transplanted those patients suffering from Fanconi anemia. We are using bone marrow for all sorts of stem cells. As you can see, the dose of cyclophosphamide is very little. It's about 40 milligram kilo total. So it's 10 milligram per kilo from day 6 to day -6 to -2, because as I was telling to you, those patients are particularly sensitive to that drug. And if you're increasing that dosage, then the patients will present toxicity and will, in a way, probably die from the conditioning regimen. So that was an enormous work from Mrs. Glickman to try to improve this cyclophosphamide dosage and reasoning that in that specific setting, you need 10 times less chemotherapy because since those patients are not able to repair the DNA, if you are bringing the same dose of cyclophosphamide, then they will probably die from toxicity. Fludarabine, very classical, and ATG, as I was telling to you, we are using it in both settings. For TBI, we are still using the lowest dose possible to avoid cancer complications, but we are still using it in unrelated settings to avoid graft rejection, and that was also something that our US colleagues are doing. So, of course, there is also the situation where the patient should be transplanted because he's transfused, but there is no donors, and so you go for alternative transplantation. So we should acknowledge the immense works that has been done by Carmen Bonfim. I see that she's on that slide, but she's not on the other one. He did a very huge work trying to make those Aplo setting working in Fanconi anemia patients, especially, but because in Brazil, you need to transplant these patients, and she had a lot of haplo donors. So she tried to have those ATG approach and cyclophosphamide post-transplant approach in those patients. As you can see, we reduced drastically the dose of post-transplant cyclophosphamide to 40 to 30 milligram per kilo to avoid the toxicity. And as you can see, the results were not so bad, and especially with ATG. So being transplanted with an alternative donors in that kind of disease and presenting a almost 80% and 70% overall survival at 2 years was very encouraging, and especially because there was some room for improvement using ATG. So that's what we are testing at the moment. So this is what we are using in France. This is a clinical trial. This is experimental. We are testing it. We have already 10 patients included. So we are trying two approach. One that is mostly pediatric. It's an in vitro T cell alpha beta depletion, and I showed you here the conditioning regimen with a GVHD prophylaxis by cyclosporin alone. And the other one, it's an in vivo T cell depletion, so an Aplo transplant, but using Campaz, because Campaz is really something that a drug that is highly immunosuppressed, that is well supported by how Fanconi patients, and you see that we reduced again the dose of post-cyclophosphamide post-transplant to 25 milligram per kilo 2 days to avoid again this toxicity. So we spoke about sibling transplant, match-unrelated donor transplant, alternative transplantation, but we should spoke about clonal evolution, because there is more of the patients that you will probably gain at the time of MDS or ML transformation. And of course, since they are kids, they are doing quite well. He wants to propose something to those patients. So this is this very nice patient paper, again, 13 years ago. I was published by Mohammad Hayes on 113 patients. And he was retrospectively assessing through the CIBMTR dataset all the patients who were transplanted for clonal evolution, MDS, AML, or cytogenetic abnormalities only. And what he was showing that even transplanted at that stage, the results were not so bad. And most importantly, of course, if you are transplanted from a matched family donor and at a young age, you're doing better. But look, you are also doing better if you're transplanted at the stage of cytogenetic abnormality only, before florid transformation. And that's important, and I will show you in a minute what kind of clonal evolution we should consider to do transplant in those patients. So that's another approach that we were thinking to do in those patients, a sequential regimen strategy. So in other words, if the patient is presenting the florid transformations to ML and MDS, since he's presenting DNA repair, you're not going to be able to give chemotherapy because the patients will keep still going in aplasia. They will not recover, never. So you have to propose something that is able to reduce the tumoral mass and then to go to transplant. So that's what we did in France. We had, I would say, a good rates of success, 5-year overall survival of 60%. On the other way around, the US colleagues were not doing it. They were going straight forward to transplant with a common chemotherapy, but without any spice before between chemotherapy and transplant, because you see those patients will never recover. So I would say you could do whatever you want, because sometimes we prefer to go to transplant when the blast counts are low. But what is very, very important is to retain that the risk of prolonged chemotherapy related aplasia, it's very high in this setting of patients. So if you want to give chemotherapy or beforehand or as a sequential approach, you should please secure a donor. You're not gonna do it like it. You're not gonna do it just we go chemo and then we wait that the patients will recover, because they will never recover. So this is what I was telling to you. We wrote this review, and John was doing a wonderful job because he knows perfectly how it's working in Fanconi patients, and we were trying to draw some recommendations according to the workup and staging to go for treatment. So there is some, I would say, easy situation when you have some patients who are presenting a florid AML or MDS and should be transplanted. If you have a patient that is presenting clonal evolution with +3q or -7q or ranks 1 abnormality or complex karyotype, even if the blasts are low, you have to go to transplant. Those patients are transforming themselves, so there is no way there is an indication for transplant. And as you can see, we were discussing the role or possibly the interest of doing a chemotherapy before transplant with according to the blast counts. If you have more than 10 blast counts, then you go for a sequential strategy or chemo and transplant. If you have less than 10% blast, since the cells per itself are also more sensitive to chemo, you could go to a classical transplantations without any chemo or sequential approach before, because basically the cells are more frail and susceptible to be killed by a common conditioning regimen. On the other side, you have the patients who has no clonal evolution, so we are doing a yearly bone marrow failure aspirations to check and to see if the patient is reaching the criteria for transplant. And on the middle, you have some patients, as you can see, that have some clonal evolution, but that are not indicating a clonal evolution early on or soon or approaching. Those are some specific cytogenetic clonal evolution that should not indicate for transplant will be less than following those patients and seeing what's going on. Then I will finish my talk by the long-term issue. And as you can see, once transplanted, while we are observing a kind of plateau in all the other disease, in Fanconi patients, they are still dying. And why they are still dying? Just because those patients are presenting secondary malignancies. And you can see how those secondary malignancies are ticked to the cumulative incidence of death. So that's why we are following our patients even long-term post-transplant very regularly, every 6 months, with a stomatologist, with a gynecologist, with an hematologist, to check and to find the transformation very early, to be able to give surgery and to avoid chemo or radio that are killing our patients. So secondary cancer is really a problem in those patients. It's very high rates of the general population. We do know that it's higher after transplantation. We do know that it's related to prior chronic graft-versus-host disease, and it's associated with patients presenting clonal evolution. We do know that surgery is the only curative treatment. That's the reason why a mandatory close follow-up is essential in our patients. A few words on the other treatments that, as I was telling to you, are not curative. They might help in some situation, or because you don't have access to transplant, or because the transplantation itself is too risky. You don't have a matched donor, so you want first of all to try something else. The androgens have really played a wonderful work in this disease, benazole, oxandrolone, or oxymetolone. There is a response rate that is very high. The only problem is that we are speaking about kids, and exposing kids to this kind of treatment might expose them, of course, to toxicity. So there is virilization, there is liver function problems. So we have to be careful in following them carefully also, because we have some liver cancer and liver adenomas. So makes us very sensible to those questions. And that's the reason why we are really reserving this approach to patients who cannot be transplanted. Again, just a word on metformin. I was a approach that was done by our US colleagues, coming from some scientific rationale, saying that we could reduce the inflammatory setting in Fanconi patients. There was 14 subjects who were treated, one who had a toxicity at the GI tract. As you can see, the response rate is quite low. It's about 30%, and that's not something that I will recommend to do in those patients. Of course, there was no complications, no disease progressions, no clonal evolutions, but overall, I think that we don't have a very efficient treatment using metformin in this setting. Finally, L-Trombopag, obviously, you do know, and I'm presenting to this group the results of the L-Trombopag associated with OSITG plus cyclosporine in the acquired aplastic anemia setting. Wonderful results, tremendous improvement of response, standard of care at the moment for those patients who are not eligible for transplant. Here, we are in another setting, and I will not be so enthusiastic using L-Trombopag in patients with Fanconi anemia. Our Spanish friends published a trial on EGH this year. And as you can see, again, the rates of response was about 30–40%, so not that much. And that's not something that, is really helping in the clinical side. There is an NIH trial. I don't see the publication yet. The prof has missed something because he was presenting at ASH last year. And when NIH is presenting something, it means that it's almost accepted. But again, as you can see, it was a lot of, it was not toxic, but the response rates were not that terrific. So this would be my conclusion. Very rare disease, very complex disease at the genetic side, but also clinically speaking. As you can see, there is a continuum from birth to death, coming from pancytopenias through early cancer and AML and MDS transformation. So diagnosis is easy to do, at least for most of the patients with a hypersensitivity to ICL. And then we go for a genetic test on fibroblasts, because I told you they can have some genetic somatic rescues that might avoid to do the diagnosis. And as treatment, I was telling to you, the main cornerstone is transplantation, and we are trying to foster it and to improve it to render it less toxic. But you see that it's not just transplantation. You need to continue on following those patients lifelong, because then they are presenting cancer, at least half of them. And if you want to cure, you have to take it out very early on. So with this, I'd just like to acknowledge all the people who are working with me on that topic, on PNH, on aplastic anemia, and inherited disorder-acquired disorders, digital transplantation. I mean, they are all doing a wonderful job, and I'm just the voice of them, and it's a group work, and always happy to share all the results we are generating with them, with you guys. Thank you very much for your attention.
Thank you so much, Dr. Leto. Wonderful talk, very crystal clear, superb. Thanks a lot, sir. And now I request all our discussants to please put the sign so that you can start our question answer session. Yes, Dr. Mehak Rehan, your question.
Sir, am I audible, sir?
Yes, you're audible. Please go ahead.
Thank you, sir, for a very comprehensive and insightful talk. Sir, I would like to know, sir, you mentioned that there's a high risk of head and neck squamous cell carcinoma post transplant also in these patients. So how do we screen for that? And is there any role of any vaccination to prevent these cancers post-transplant head and neck squamous?
It's a very good question. This is a challenge for the next years. I think that we successfully manage the transplant problems, and we should really acknowledge the research of Professor Gluckman who make it possible. Now the challenge is squamous cell carcinoma, and not only in transplant patients, in all Fanconi patients. So we really have to do a very specific screening systematically with some specialized, not us, some specialized from the mouth, a stomatologist, some gynecologists for women, and we have to train them, and we have to tell them that this is a very difficult disease, and they have to go through it every 6 months, because if you have something like a pre-cancer lesion, you have to take it out. you have to do biopsies, you have to be very interventionist, you have to be very aggressive, because once it's outside locally, once the disease is in the lymph nodes or do a metastasis or whatever, this is palliative care. So what we are doing is insisting, we have a kind of network in France of hematologists, with stomatologists, with gynecologists, to follow those patients very carefully. And the other thing that you have to be aware of is the symptoms, because you cannot do a the scanner to those patients every 6 months. First of all, because they are more sensible to radiation. So in the end, you will, again, higher the risk of cancer, but also because just stupid to do something very specific every 6 months to see if you have something. So you have to educate your patients, and if there is something different, pain in the stomach or a pain when it's dysphagia, and then they go straight forward for exams, and that's the way we are doing it. But it's very frustrating. That's again, and I should not say that, but as a physician, it's very frustrating because you do know the patients you are in front of you is going to present a tremendous number of problems, beginning with pancytopenias and then clonal evolution. So you're checking clones. We're checking clones every year in the bone marrow, every 6 months sometimes, to see if there is one bad clone that is appearing that might indicate transplant, or if the good clones are doing well and are not, transforming. And then you have AML or MDS, and in the middle you have squamous cell carcinoma. So we are always on their back, and the thing is that it's very difficult because, as I was trying to tell you, we cannot do many treatments, and outside transplant for pancytopenias or MRMDS, outside surgery for cancers, we have nothing to propose yet. So gene therapy was something very enthusiastic, but I learned that they stopped the program at the moment. At least they are facing very difficult problems, because to do gene therapy you need cells. So it means that you will need to harvest all patients in the childhood to prevent a potential pancytopenia coming in. So it's very not easy.
Thank you, sir.
Thank you. Thank you. One more question, sir. So you mentioned about metformin, sir. Other repurposed drugs like statins or antioxidants or NSAIDs, do they have any role in reducing the genomic instability or delaying clonal evolution?
So there is a lot of case reports on that, but there is not formal prospective trials showing anything. I should confess that for metformin and eltrombopag, we are all very enthusiastic and giving this to all our patients. And when there was a formal clinical trial, well monitored with clear endpoints, it was a failure. So just to say that for the moment, there is no clear evidence to use it in that setting.
Thank you. Thank you very much.
Thank you, Dr.
My
Mehta.
pleasure.
Same note, what about Alphamopec?
So eltrombopag, I mean,
Yeah.
there is two trials going on. There was one published by the Spanish group, and the other one by NIH has not been published yet. We didn't have some good results, but it's would say clinical evidence. It's not published for France. So for the moment, I mean, it's not working so well, which kind of normal, because since there is few stem cells and the process is not immune, I mean, you're just stimulating very few cells, so it's not surprising that you don't have a very big results.
And the same is true for romiplostin also, sir. That also doesn't work much.
So it's a good question. I didn't see any case reports using romiplostin. It should not be different, but I don't have enhanced papers that is supporting my answer. So good question.
Thank you, sir. There's one question by Dr. Ali Mahmoode. Can you please tell about the fertility performance of Fanconi anemia long-term survivors?
Yeah, very nice question. Well, the same. They are problematics. They are hypofertile, and especially because obviously all the cells are suffering the same problems. So the young patients are sterile about 20 years of age, and the fertility is really altered. We had an ongoing study in France mainly clinical. We had some patients that were pregnant, mainly before transplant, and one after transplant, which was a miracle. But yes, fertility is a problem in that patients, and they are really hypofertile.
Thank you, sir. There is one question from Dr. Karthik. Any experience regarding the use of quercetin? I don't know what that means.
I didn't understand.
Yeah, it's QURCETIN, quercetin.
I don't understand. You can write it, perhaps.
Yeah.
See it.
So I think it's quercetin. Anyways.
Quercetin. Yeah. Quercetin. Thank you. Yeah. No, so we I know that some of our colleagues are using it. We did not do it. There are some results that seem to be in favor, but again, there is no any good study on it.
Thank you, sir. There's one question from Dr. S.K. Sharma. Does renal involvement have any bearing on decision for bone marrow transplant or any long-term results?
So those patients are not exposed to kidney insufficiency usually because they are not exposed to cyclosporine and all those other kidney toxic problems. However, we have some patients that have only one kidney and not two. So that's those ones who are really very careful. And that's the reason why the pre-transplant checkup is really outstandingly high because we want to know if they have a normal function and so on. But usually it's not a big problem. And what we are doing, because at the moment there is a clear, I think, question worldwide, is a cyclosporine-free regimen for aplastic patients. But this is outside Fanconi. This is for all aplastic patients because most of the time we are facing usually patients with cyclosporine toxicity for kidney, and more older patients are coming in with kidney insufficiency. So we are trying to design, to set up, we have a workup at the moment at the French level to design this platform with cyclosporine-free regimen.
Thank you, sir. Dr. Gopinathan, your question.
Good morning, sir. Thanks for that wonderful talk. So I have two questions. The first question is, suppose if some patients, when they present with AML or MDS, and if they do a chemotherapy, do you have any specific, and in the hindsight, we suspect a bone marrow failure syndrome, do you recommend any time interval between chemotherapy exposure and doing a chromosomal breakage test?
So what I recommend is not to miss one patient with Fanconi disease. So in other words, if you have a patient with AML MDS early on, I mean, when you have a patient that is presenting AML MDS with features that might make you think about the Fanconi disease with malformations and such things like this. If you have a patient with 35 years old, never take a single cigarettes, and is presenting with a squamous cell carcinoma, think about Fanconi and do the breakage test. And afterwards, you will have the diagnosis and you go further for the treatment. For your question specifically, what I would recommend if you want to do chemo, of course, you have to use non-alkylating agents. And please you have to secure a donor. You're not going to wait that the patients will recover from aplasia because they will never recover from aplasia. So you do the chemo, or you do the sequential approach, and you do transplant straightforward after it.
Sometimes we do see patients where the phenotype is somewhat looking like a Fanconi phenotype, but the mitomycin score that we get cut off is more than 40. We get the score somewhere between 30 to 40. How do we approach these patients in algorithmic fashion, sir?
Yeah, very good question. This is because of mosaicism. So in other words, I was presenting to you 15 to 20% of our patients are presenting natural somatic genetic rescue. So the breakage test will be negative because they have a conversion, a reversion, and then they are not biallelic mutations anymore. So they had a normal blood. So in those patients, you have to go to genetic screening. And what we recommend is skin fibroblast, and then you send to us. You can send to us or to anybody a DNA, germline DNA, so that we can, of course, test for the gene, and then we'll find the B allelic mutations and do the diagnosis.
Yeah. A couple of patients we have stuck with in a similar fashion, sir. If at all we need to send it across to you, like how do we just need some basic information, how to send across to you and all that, sample transport and all that.
We could, I mean, first of all, you send me an email and I will put you in contact with Professor Soulier and we'll arrange this. Or blood, but most of the time it's easier to do fibroblasts, frozen fibroblasts, but we'll find a way. Or swaps, we'll find a way.
Sure, sir. Thank you, sir.
Thank you, Dr. Gopinathan. So, sir, if your stress cytogenetics, that is chromosome breakage analysis, is negative, and still you are suspecting based on the clinical features that it can be Fanconi's, I think it is must to go for fibroblast testing for all the
Yes, exactly.
before we start any treatment.
Well, it depends. It's always the same. It depends the number of features that make you think about Fanconi patients. If you have really a high risk of Fanconi patients, you should not begin chemo before, because you're going to expose the patients to a very high risk of toxicity. And you need to reduce the dose drastically. And on the other way around, you cannot reduce the dose drastically in a patient that is not Fanconi, because then you won't be efficient. So again, we do have some multidisciplinary meetings 2 times per month. It's the first and the third Wednesdays of the month, and it's by Visio. And this is typically some patients, when you have some difficulty, we could discuss it together. I mean, you just send me an email and then we see. And then all together we can see if there is enough evidences to think that the Fanconi must be eliminated before going to chemo, or if basically this is quite, smooth and we could go forward. But this is something we can discuss. It's always difficult to draw some general recommendations just like this. I mean, it's really a case by case specific discussion.
Thank you, sir. So from the same note, if a young patient who is 25 years of age comes to you with cytopenia and on bone marrow examination, there is shows about 13-14% blast. So considering the young age at diagnosis and coming with cytopenia with 13-14% blast in the bone marrow, if we are not ruling out Fanconi's and we are starting the patient on, say, for example, azacitidine venetoclax, which is very common setting in India. So does it has an impact on the recovery of counts, or is just a chemotherapy?
So it should be less toxic than using other chemotherapy first. And
Okay.
second, I mean, it depends in these patients if you have some arguments. I mean, if it's small, if it has growth retardation, if there is a family history, if he has some specific dysmorphia, if he has only one kidney, you see, you will find a way to do the diagnosis and to think about.
Exactly, so. Thank you so
Because
much.
this is a peak. I mean, acute ELL, it's really at 20 years, it's a peak. So if you should test everybody, I mean, it's going to be a nightmare. But those patients are small. There's always something different from the other ones.
True, sir. Thank you so much. Dr. Nilesh? You're muted, Dr. Nilesh. You're muted.
Okay. Hi, Dr. Amit. Hi, sir. The lecture was very nice, and I have 2 patients basically. Cases of aplastic anemia, no features of Fanconi. Age group is 40 to 45, and chromosomal breakage was negative, but NGS for aplastic was done, which was showing Fanc mutation. So they could not afford a BMT. They were ready for IST therapy, and with the due risk and everything, we have given IST, and those 2 patients are doing well. So how do we explain this? Like, should we those Fanc mutations were really true or not? I don't know.
Yeah, well, first of all, I mean, you can find some Fanc mutations in all patients.
Yes.
In other words, we have finding some myeloid cancer gene mutations in our patients, and it's not because of this in aplastics that they're going to transform to MDRs. In your patients, what happened is probably that first of all, it's depending the VAFs, that probably will be low, so it might be a somatic mutations. And second, the things that you have to be proven if it's a biallelic mutations on the same genes, because you can have also two different and we have a case recently in Italy with two FANC mutations, but not in the same gene. So the patients were still heterozygous, and then the breakage tests were negative. And so, yes, of course, the patients was presenting this, and it was misleading. But in the end, since he responding to immunosuppression, you have the end of the story. It was an acquired aplastic anemia, and not enough to go through Fanconi patients.
Yes. Thank you so much.
My pleasure.
Thank you, Dr. Nilesh. Finished all the questions from the audience. Yeah, anybody has any other question? Fine. So that's all, sir. Thank you so much for wonderful.
My pleasure.
Fantastic lecture, very crystal clear lecture. We learned a lot from you, and we are keep on learning in future also, sir. Thank you so much.
Thank you. Have a great day.
Thank you, sir.
Talk to you soon.
Thanks a lot.
Bye-bye.
Thank you. Bye-bye.